So this, I think, was the last thing that we talked about. We talked about regulating the kidney. We talked about autoregulation, which is the kidney regulating itself. We talked about it controlling the afferent, and then we started talking about extrinsic control. So when you're talking about extrinsic, what system is controlling the kidney? Not the kidney, right? And which one did we talk about? We talked about the nervous system, sympathetic nervous system. Right. So I think this is the last, we didn't get to this, right? So on here, the role of the baroreceptor. What's baroreceptor measuring? Pressure. It's measuring blood pressure. So if your baroreceptors detect a low blood pressure, what do you think the nervous system's going to do? If you have a low blood pressure, don't even think about the kidney right now. Think about what you know from the past. If your blood pressure drops, what's your brain going to say? We need to increase the blood pressure, so what's it going to do? Increase what? What system? The sympathetic nervous system. So you want to go back to the things you already know, and this is going to apply to the kidney too. The baroreceptor detects that stretch, right? That pressure. Where does it send the signal to? Almost pointed to it. Where does it send the signal to? That's where the baroreceptors are at. Where does it send the signal to? So you're right. The receptors on the aortic arch and the carotid sinus. Where is it sending a signal to? Medulla oblongata. Since it's the medulla oblongata, the medulla says do what with the sympathetic nervous system? Turn it down or turn it up? Turn it up. It releases what chemical? Norepinephrine. Yep, so it's going to release norepinephrine. It's going to stimulate the blood vessels to do what? Constrict. Think about the afferent arteriole. Now we're going into the kidney. It's going to constrict the afferent arteriole. What's going to happen to the flow into the kidney? The flow decreases. What's going to happen to your filtration rate now? Decreases. What's going to happen to your urine production? Decrease. What's going to happen to your reabsorption? Increase. Why is it reabsorbing? Because it's trying to add volume to the blood to do what? What started this whole pathway in the first place? It was started because of drop in blood pressure. You're trying to regain the blood pressure, bring it back up. So it's a whole process. If the baroreceptors detect a low arterial blood pressure, it sends a signal to medulla oblongata, increases sympathetics, increases epinephrine or norepinephrine release. That's going to cause constriction of the afferent arteriole that's going into the kidney. That decreases flow, decreasing filtration, decreasing urine production, and increasing reabsorption and blood volume, returning the blood pressure back up. Just think of the pathway. You already know half that pathway you had to know on the last exam. Now you have to add it to or apply it to the kidney. And if you knew that, then the baroreceptors, if they detect high blood pressure, what are they going to say? What are you going to do to the sympathetic nervous system? Turn it down. Turn down the sympathetic, so you're going to stop releasing epinephrine. What's going to happen to those blood vessels? They dilate. So the afferent arteriole dilates. What's going to happen to the flow in the kidney? Flow goes up. What's going to happen to your reabsorption rate? It's going to go down. What's going to happen to your urine production? It's going to increase. You're going to put out more water in your urine. So think about the big picture again. If you have low blood pressure, what color will the urine be when it's produced? Light yellow or dark yellow? Very dark yellow. Why? Because you're reabsorbing the water. You're concentrating your urine, you're reabsorbing the water. If you have high blood pressure, what's going to happen to the color of that urine? It's going to be more clear because you're pushing more water out to try and drop the blood volume and drop the blood pressure. So here's where you're mixing cardiovascular with kidney. You have to know those pathways. And if you like flowcharts, here's the one from your book telling you that pathway. So if you have a drop in arterial blood pressure, aortic arch, carotid sinus detect it, turns up the sympathetic activity. You already know what's going on with the heart. Cardiac output's going up because the heart's increasing its heart rate and it's increasing its contractility. So sympathetic, remember, affects cardiac output by increasing heart rate and contractility. Right? And then you're going to start squeezing those blood vessels. When you squeeze the blood vessels, it it shuts down or slows down the flow into the kidney. So what's going to happen to your filtration rate if you have slower flow? Filtration rate goes down. Remember glomerular filtration rate. You make less urine and you reabsorb more. bringing the blood volume back up. When you bring the blood volume back up, it raises your blood pressure back to normal. When we talked about cardiovascular and the flow of the different organs, we talked about the kidney and the brain. Together, they represent less than 3% of the whole body, but together, they take about 40 to 45% of all the blood flow. So super important organs. Why is the kidney so important? Why is the kidney so important? What's it do for your body? It filters toxins out of the blood, the bad stuff out of the blood. So when you're making too much urea or too much acid, it'll help clear out that acid and urea. If you're making too much bicarbonate, it'll do the same thing, clear the bicarbonate. It keeps the blood fit for the rest of the body. Okay, next process, tubular reabsorption. So we talked about filtration. You have to understand filtration. What type of filtration specifically was it? There was a name before it. Glomerular filtration, right. So where's it happening? At the glomerulus. The only time you're having filtration in the kidney is at the glomerulus. So glomerular filtration. Now we're talking about tubular reabsorption. It's taking it from the tubule and reabsorbing it to, where is everything reabsorbed to? The blood. Yep, so it's bringing it back in the blood. This is a more complex process. When you're talking about glomerular filtration, you're talking about a spaghetti strainer. You pass the blood through the strainer, and it lets water and sugar and salt and everything leak out, amino acids leak out. It's an easy process. It's passive. Tubular reabsorption is a 5-step process, and it's very selective. So very selective. Filtration was not selective. It was non-discriminative was the word that your book used. This is extremely selective. This requires energy. So anything that you're reabsorbing must be what? It's an active process. What's your body think of the stuff you're reabsorbing? It must be important. It has to be valuable or important. So what things did we just talk about that leaked out, that got filtered, that you don't want to lose? Amino acids? Sugars, yep, so glucose. You want to keep those kind of things as things that are important to your body. You try and reabsorb them. So your body puts energy into pulling them back in. Right, but 5 steps. So when I went through these, I underlined each one of the major steps instead of remembering every step written out word for word, the main points. So the first thing you want to think about, you have this filtrate, right? So this pre-urine. This pre-urine, if you're trying to reabsorb something, you're trying to get it from this pre-urine area all the way over to the plasma. The first step is going across from the lumen into the cell. So the luminal membrane is the first. And in the notes I have, do I actually have written luminal membrane? Yeah. Yep, and that's exactly what I have underlined. And then from the luminal membrane, what do you call that fluid inside the cell? Cytosol. So it has to go across the lumen membrane, then it has to go all the way through the cytosol. It moves to the cytosol by diffusion, remember? So high concentrations coming in, it flows across. So that's 2 steps. The third one's what we call the basolateral membrane. So if you remember your anatomy, they talked about the basal membrane is the membrane that's always between cells and the plasma. The lateral means to the side. So basolateral membrane. So first word was luminal membrane, second word was cytosol, third one basolateral membrane. Bless you. The fourth process is moving it across this space. What do you call this space between cells? Interstitial. Yep. So you have to move it through the interstitial space or the interstitial fluid. Same idea. You're making a high concentration here, so it's going to flow across in this direction until it finally moves over. What do you call the wall of a blood vessel? So the capillary wall, or what's that E word? The endothelium. Yep. So you can think capillary membrane or endothelium. So 5 steps. It's a kind of a long process getting it back in. It takes a lot of work for your body to pump that stuff across, move it in this way, and then finally get it into the plasma. And if you're spending energy bringing it back in, it has to be important. And they call that transepithelial transport. All right, so some of the things you're going to be moving. Water, glucose, sodium, they're totally reabsorbed. You want as much as you can. Urea is kind of the exception to the rule. Urea is about 50% reabsorbed. Urea is kind of that fluky thing. You don't want to accumulate too much urea. If you accumulate a lot of urea and it doesn't get filtered out into your urine, it starts sticking in your joints and it starts forming crystals in your joints. Anybody know what disorder that's called? Gout, exactly. So think about this. Who's going to have the most risk of gout? Think about people in their kidneys. If your kidney's trying to actively push most of it out, but it's going to reabsorb some of it, who's not going to be able to clear that from their body very easily? People with kidney disorders or people that are older. As you age, nephrons slowly start dying off. So as you get older, you can't get rid of the urea very efficiently. Urea starts accumulating and then it starts sticking in the joints. And what's really scary is the colder parts of your body, when the urea gets colder, it starts crystallizing faster. So when these people go to sleep, what happens to your body temperature? It starts dropping, especially what parts of your body? The extremities. So where do they usually accumulate these gouty joints at? In the toes, yeah. So especially the big toe pointing out there. And if you were to actually cut it open, there are little tiny crystal particles inside of it. I can only imagine how painful that would be. All right, so tubular reabsorption, two types, passive and active. The active reabsorption revolves around sodium. Everything that's passive revolves around sodium being pumped. What kind of transport do you technically call that passive? Secondary active, right? It's because of the active that you're having this passive reabsorption. And when we talked about absorption in the GI tract last week, we talked about sodium being moved with what two other special chemicals? Sodium is responsible for helping you get these two nutrients into your body. What are the three major macromolecules we talked about? We talked about lipids, proteins, and carbs. What two depended on sodium to get into your body? Carbs and protein, right? So you break them down into the simple sugars and the simple amino acids, and you transport them across. It's the same process here. It's exactly the same process, except you're in the kidney now. So to reabsorb amino acids you accidentally lost, you have to have sodium pulled back in with it. To reabsorb glucose that you may have lost, you have to have sodium pulled back in with it. So we'll talk about sodium right off the bat. So sodium, when you move it, it's energy dependent. It requires what then? Well, by sodium potassium ATPase kind of tells you. You have to have ATP. Yeah. When did we talk about a sodium potassium pump before? When we talk about membrane potential, exactly. It's the same pump. When you pump sodiums into the kidney, what's happening to the potassium then? You're pumping potassium into the urine. You're pumping it into the urine. So if you're reabsorbing a lot of sodium, what are you losing a lot of in your body? Potassium. It's one of those trade-offs. Okay. So where you see those pumps on the basolateral membrane, I'm going to click back a couple, right here. So you find the sodium pumps here. Sodium is being pumped into the interstitial space, and the potassium is being pushed out here and then eventually out into the lumen. And it helps maintain that concentration gradient so everything else can come in. Right? 80% of the energy their kidney uses to try and move sodium. Remember, the other things move with the sodium. So like I said before, sodium, your body wants to keep as much sodium as it possibly can unless you have way too much. Then your body will let go of it. Where are you reabsorbing these things, you have to know. So when we talk about like glucose or water or sodium, you want to know where you're reabsorbing it. So 99.5% of the sodium is reabsorbed through the kidney, which is practically 100%. The first part is in the proximal tubule, the bulk of it. About 2/3 of all the sodium is brought back in the proximal tubule. Remember, proximal tubule is the very first step outside of, you go to the glomerulus, to Bowman's capsule, and then as you start going through the tubule, it's the very first set of tubules. What you're going to find is that most of the things are reabsorbed in the proximal tubule. When I was learning about the kidney and what gets reabsorbed and where it's reabsorbed, I started thinking about it. It's kind of like my sister's purse. When she wants to clean out her purse, the glomerulus is like her cleaning her purse. She dumps everything out, just indiscriminately. So she just starts dumping everything out. Her wallet, her money, her lipstick, all the stuff starts going on the table. It's like the kidney just starts dumping things like amino acids and glucose. Do you want to lose those? Nope. Did she really want to get rid of those out of her purse? The lipstick and all that stuff? No. So what'd she do? Flips the purse back over and then pulls back in about 80% of it right away. Right? She leaves the hamburger wrappers and the gum wrappers and all that on the table for my mom to clean up later. But your kidney's exactly the same way. It starts dumping things out at the glomerulus, just indiscriminately dumping things out, and then right away in the proximal tubule it goes, oh crap, I want this, I want that, I want this, I want that, and it starts pulling all this stuff right back in as fast as it possibly can. So most of what you get pulled back, like sugars and amino acids and sodium, is going to get pulled back right away in the proximal tubule. So that's how you want to remember that. All right, and then 25% in the ascending limb. So what's right after the proximal tubule? The ascending or descending limb? The descending. So how much sodium is absorbed in the descending limb? None. Nothing at all. 0% is absorbed in the descending limb. And there's a reason for that. We'll talk about it later. So 25% in the ascending limb of the loop of Henle. And this is going to help concentrate your urine. Right. And then the last 8% is in the distal tubule and the collecting duct. So that last 8% is the part you can modify. You can't change the 67% in the proximal tubule. You can't change the 0 in the descending. You can't change the 25 in the ascending. This last 8% is the flexible amount. So what's going to happen if I have way too much salt? I ate a bag of pretzels. And now what's my body going to think? What's it going to do to that 8%? Raise it or lower it? It's going to lower it. It's going to reabsorb less so that you push more salt out into the urine. If I eat a whole bag of pretzels, what's going to happen to my blood? It becomes salty, and what's going to start chasing that salt? The water. So what's going to happen to my blood pressure because of that bag of pretzels? It's going to start going up if my kidney doesn't regulate something. So my kidney's going to say, whoa, that's way too much salt, that's way too much water. I'm going to drop this reabsorption, and I'm going to push more salt and water out into the urine. So that last 8% can be adjusted. The other 3 can't. The 67, the 0, and the 25%. And how it adjusts this is this process called the Renin-Angiotensin-Aldosterone Mechanism. Underline it, put a star by it, or 2, or 10. Maybe a little circle, smiley face, happy face, a wink wink, whatever you have to put by that, because this you're going to see again in this class and beyond this class. This process is a huge regulator of blood pressure. So much so that one of the most significant drugs out there regulates this mechanism to help you regulate blood pressure. Okay, so that 8%, it's under humoral control, basically from the other fluids, so you can think hormonal control. And it's because of this renin-angiotensin-aldosterone system. Aldosterone, what you want to know right now, aldosterone makes you keep sodium. If aldosterone's working, it's going to make you keep sodium. What's going to happen to your blood pressure as a result? It's going to go up because you're also keeping what? Water. And when you keep water, you increase your volume, which increases your blood pressure. So aldosterone keeps sodium. This next one, atrial natriuretic peptide, when you see this word, well, number one, where's it made at? In the atrium. Right, so it's made in the atrium of the heart. When you look at this word natriuretic, that uretic sounds like what other word? Like a diuretic. What's a diuretic make you do? Get rid of lots of water. This is like a diuretic, but it's a natriuretic. Look at the Na and imagine that as being a plus. What's it getting rid of? Sodium. The natriuretic's in sodium diuretic. You can think of it that way. So aldosterone makes you keep salt. A and P is the abbreviation for this. Makes you get rid of salt. What's going to chase that salt wherever it goes? Water. Why on earth would atrial natriuretic peptide make you want to get rid of salt then? Why would it be released? If you ever wonder what a chemical does or why it's released in the first place, what was its final effect? It makes you get rid of salt and water, which is going to do what? Drop your blood pressure. What must cause the release of A and P then? High blood pressure. What kind of loop is that called? Negative feedback loop. If your blood pressure goes up, your heart goes, oh my God, I got to get rid of some of this water. It releases this atrial natriuretic peptide that goes to your kidney. It makes you get rid of salt and water, doing what to your blood pressure? Dropping the blood pressure. How's the heart feel now? Relieved. So it stops releasing A and P. Get used to seeing negative feedback loops in hormones. These are both hormones. So here's your process. Here you have that pre-urine, the filtrate. You're going to bring in the sodium. The only reason the sodium is passively moving through this membrane is because down here you have a pump. Just like we've talked about before, the secondary transport. If you have a pump here pumping out sodium into the interstitial fluid, what's it doing to your concentration of sodium inside the cell? If it's pumping sodium out of the cell, what's it doing to your concentration in the cell? It's decreasing the concentration, making it low. So if you have any salt out here, and this is low, where's the salt want to go? It wants to go in. And then this pump pumps more out. It's always maintaining that concentration difference, just like we talked about pumps in the past. So the sodium gets pushed out here, gets pushed, and it starts accumulating in the interstitial fluid, and then it diffuses into the blood. What's going to chase it all the way across here? Water. Yep. As you bring sodium in here, water comes in too. You push sodium out into the interstitial fluid, water goes with it. You push sodium into the blood, water goes with it. That mechanism I told you, definitely, absolutely, positively want to know. For real, for this semester. Actually, you want to know it for this test, and you'll probably want to know it for the next test. It's hormones. The last test has a lot of hormones on it. So renin-angiotensin-aldosterone, may as well commit it. When you look at this, the keys you want to remember is first where the hormones are released from. So the granular cells of the juxtaglomerular apparatus, when we were talking about that structure, I thought I had a picture, I guess I don't. So right there where the afferent and the efferent arterioles revolve around what ball of yarn looking structure? The glomerulus. So remember, juxtaglomerular apparatus is juxta next to the glomerulus. So you have these cells, the granular cells, when they detect high blood pressure, they're going to release this stuff called renin. Is that up there? Yep. Okay, so you definitely want to know renin. I'm sorry, did I say high blood pressure? When it detects low blood pressure, because what's the overall effect of this thing? It releases aldosterone. What's aldosterone going to do? Keep salt. What's it going to do to your blood pressure? Raise it up. So what would always be the cause if the final effect was to raise blood pressure? A drop in blood pressure. All right, so renin, you want to underline renin. It's a hormone. Renin, if it's a hormone, how does it travel through your body? In the blood. It dumps into the blood, it travels around in the blood, and it's looking for its target. Its target is this stuff called angiotensin-O-gen. What do you know about it? It's inactive. It's also in the blood. So the liver is making this angiotensinogen, and it's circulating all over the blood all the time. When you start dumping renin out into your system, renin is going to find this angiotensinogen and bind to it. When it binds to it, it's going to cleave it. It's going to break it apart. But not break it into an inactive form. It's going to make it more active. So it turns into this stuff called angiotensin-1. So now angiotensin is floating through your blood. When you watch this angiotensinogen to angiotensin-1 to angiotensin-2, there's a reason that there's a three-step process of activating this stuff because it's extremely powerful. It's like having a hand grenade. It's so powerful you have to have 2 pins in it. Just in case you accidentally lose 1 pin, you've got a backup. Okay, so angiotensinogen is released from the liver. It's circulating through the blood. When renin binds to it, it turns it into angiotensin-1. Angiotensin-1 goes up into the lungs and it finds an enzyme in the lungs. It's called ACE, angiotensin converting enzyme. That ACE activates angiotensin-1 into angiotensin-2. When it becomes angiotensin-2, now it's extremely powerful. So number 4 says all of the effects of it. So angiotensin-2, one thing it's going to do is increase aldosterone production. In fact, I'm just going to flip to the next. So here's the process. Angiotensinogen turns to angiotensin-1 because of renin. Goes to the lungs and finds that angiotensin converting enzyme. Now it's angiotensin-2. Look at all the pathways that are coming off of this thing. Right? So one pathway, it's going to go up to your adrenal cortex and it's going to make you release aldosterone. So it goes to the adrenal cortex and releases aldosterone. What's aldosterone going to do to the kidney? Make you keep sodium. If you keep sodium, what do you keep with it? Water. Yep. So right now, aldosterone is making you keep salt, which indirectly makes you keep water, which is going to do what to your blood pressure? Spike it. Yep. The next thing angiotensin does is it's going to find as many blood vessels as it can and starts vasoconstricting. You know that as soon as you vasoconstrict, what happens to your blood pressure? It goes up. So now you have 2 things cranking up your blood pressure. The third thing it does is it goes to the thirst center in your brain. Do you remember where that would be? Freezing, feeding, fighting, and fornicating. The hypothalamus. It goes to the hypothalamus. It tells the hypothalamus bring more water in. It makes you crave water. When you drink more water, what's it going to do to you? Makes your blood... First, it makes your blood volume go up. and then it makes your blood pressure go up. There's 3 ways it's raising your blood pressure. Okay. Next, it's going to cause you to release this stuff called vasopressin. And we talked about this before. What's it going to do to your blood pressure? Vaso means vessel. Pressin is a pressure causer. It increases blood pressure by causing vasoconstriction. There are 4 ways it's making your blood pressure go up. A little bit goes a long way because it has 4 different methods for raising your blood pressure.
I'm sorry, could you just repeat that last 4th way?
The vasopressin.
Uh-huh.
So angiotensin releases vasopressin in the hypothalamus again. So it goes to the hypothalamus and causes you to drink water and also causes you to release this chemical vasopressin. Yep. Vasopressin is going to cause vasoconstriction. And then the 5th thing it does is that vasopressin goes to the kidney and causes you to reabsorb more water. What's that going to do to your blood pressure? Raise your blood pressure. The moral of the story is, what does angiotensin do to you? It makes you spike your blood pressure. So if you had high blood pressure, what do you want to do to angiotensin 2? Increase it or decrease its activity? Decrease it. So you need to find something that inhibits it. So you need to find something along this pathway that you can inhibit. Anybody already know where I'm going here? An ACE inhibitor. When somebody takes an ACE inhibitor, it inhibits that enzyme. So can you activate angiotensin 1 to 2? Nope, which means none of these processes happen. What's an ACE inhibitor going to do to your blood pressure then? Turns it down. It prevents that spike in blood pressure, thereby decreasing your blood pressure. So when people take an ACE inhibitor, it's because their blood pressure is too high. They're trying to reduce their blood pressure. So a super important process, and if you go into pharmacology, they're going to also abuse you with that knowledge over and over again. Okay, and then the big picture was salt. In the complete absence of aldosterone, you lose about 20 grams of salt every day. I'm trying to visualize 20 grams. That's like more than a tablespoon, probably about a tablespoon and a half. So if you were really hard up for salt, you could just filter your urine, dehydrate it, and you have that big pile of salt. Plus lots of other nutrients, right? So a little urea in there, some other electrolytes, potassium. All right. So if you're constantly releasing aldosterone, you're cranking out the aldosterone, how much salt will you release? If you're releasing lots of aldosterone, what's aldosterone do? It makes you keep salt. So how much salt would you lose in your kidney, from your kidney? You'd lose none. You keep all the salt. What would happen to your blood pressure if you were constantly releasing aldosterone? High. Your blood pressure would definitely spike up. Right. And then when we get into the endocrine system, we'll talk about diseases where people have high aldosterone release. So what do you know so far about the Renin-Angiotensin-Aldosterone system or mechanism? So sometimes you see it abbreviated RAAS, sometimes it's RAAM. It's always Renin-Angiotensin-Aldosterone. How about number 4? Angiotensin 1 is converted to angiotensin 2 in the lungs. True or false? Damn, I hate it when I go right for the right answer first. I was getting in the habit of the right answer being the first couple, so I just went for number 4, and as soon as I started reading it, you hear the shake in my voice. Like, ah! So what's wrong with number 1 then? Renin is released from the adrenal gland when blood pressure is elevated. Where's renin released from? From the kidney, right. It's not released from the adrenal gland. And why is renin released? Because the blood pressure is low. So there are 2 things wrong with number 1. Cross that one out. Number 2, angiotensin 1 stimulates aldosterone release from the kidney. Angiotensin 2 causes aldosterone release. What else is wrong with this? Aldosterone is released from the adrenal gland. Yep. So 2 things wrong with number 2. You can cross that one out. How about number 3? Angiotensinogen is made by the kidney. Angiotensinogen was made by the liver. Yep. So this is a good slide to get familiar with. Excuse me. All right, so number 4 was the correct answer. The next hormone we kind of already talked about, ANP, atrial natriuretic peptide, is released from what organ? From the heart. Yep, it's released from the atria of the heart, and it's there when what's happening in your blood or your blood pressure. It's too high. Yep. So ANP directly counteracts aldosterone. I think we just said that already. So when you have high blood pressure, ANP is released, and AMP goes down and causes you to do what with salt? Get out the sodium, put it into the urine, get rid of it out of the body. Right? So the other thing that does, it inhibits renin. If you don't release renin, what do you never activate? The angiotensin. Yep. Without renin, you can't activate angiotensinogen to angiotensin 1, so you never can activate it to number 2. And then the third effect, it dilates the afferent arteriole. So if it dilates the arteriole going into the kidney, what's going to happen to your flow into the kidney? It increases. What's going to happen to your filtration rate? Increases. What's going to happen to your urine production? It increases. What's going to happen to the color of your urine? It becomes more light in color or more clear, right? It's because you're putting out lots and lots of water. So if you like flowchart skin, here you go. High sodium chloride, so high salt in the body, high volume in the body, high blood pressure. Any of those things will trigger the heart to release ANP. And then you can see all the processes we just talked about. So it causes the afferent arteriole to open up. It causes the sympathetic nervous system to decrease, which opens up the blood vessels. All these effects trying to lower your blood pressure. All right, next, glucose and amino acids. They're reabsorbed because of that sodium co-transport process. So they're kind of passive. There's no energy put into it. But are they really completely passive? No, it's called secondary active. So it's a somewhat passive process as they're being pulled in, but it's because there's energy somewhere else. Okay. Chloride reabsorption goes hand in hand with sodium. Anytime you see sodium moving in one direction, chloride always wants to move in the same direction. What do you call sodium and chloride stuck together, dehydrated, and put on your table? Table salt. Yeah, they always go hand in hand, sodium and chloride. Which is higher in abundance outside of cells? They always go hand in hand. Which one's higher? Both. They're both high. Remember when I told you the thing of the cell is an island in salt water? That salt is sodium chloride, so it's high. All right, water moves passively, chasing what? Chases the sodium, yep. And then urea reabsorption. Urea is small enough that it actually diffuses back in, and about half of it will come back in. It goes until it hits about equilibrium. Half of it's in the tubule, half of it goes back into the blood. It's that freak exception to the rule. Right. And then other unwanted waste products like creatinine. So you urinate out creatinine that you can't process. When you exercise really hard and you're damaging those cells, sometimes the cells release creatinine. It goes into your urine. We can actually use creatinine as a measuring marker to see how well your kidneys are filtering. So we can talk about how big you are, how large size-wise, are you male, are you female, how active you are. We can look at this little chart that says, based on what we know about people your size doing this much activity, you should have this much creatinine in your urine. If it's low, then we go, uh-oh, your kidneys aren't working as well. We'll talk about that in just a little bit. So there's the water movement. You can see water just slides right across, chasing what? Yep, it's chasing the sodium. It's following the sodium in. So here's your sodium pathway moving across, and the water's going hand in hand with it. Okay, I think this is the next section in your notes. Right. So here's your filtrate, and I feel like this is out of place. Oh, I know why this is here. It's because of urea. So urea, if you push out about 124 or 125 milliliters worth of urea, how much are you going to bring back into your system? About half of it. So this glomerular filtration, as you're filtering out here, there's a process of reabsorption that you're going to bring about half the urea back in. And this deserves a little star. This kind of goes right along with diabetes, and it'll help you understand, hopefully help you understand a little bit about diabetes and why they start seeing sugar in their urine. Because if you're a normal, healthy person, should you have sugar in your urine? Nope. Is it ever possible that you'll see sugar in your urine if you're a healthy person? Yeah. What would be one good example? Sugary meal, excessive exercise, pregnancy, some things like that. Right? So the tubular maximum, and tubular maximum is basically, you can think of it as this is the maximum point of how much sugar you can put in the kidneys and reabsorb at the same time. It's the most sugar you can put in the kidneys and be able to actually absorb in a certain amount of time. When I think of it, and I should just make a picture, but this tubular maximum, if you think of 4 guys in a boat, and they each have a 1-gallon container, and the boat starts leaking at 2 gallons in per minute. And these guys can move their bucket once a minute. Can they get all the water back out? So if they're 2 gallons seeping in a minute, and they have 4 buckets, 4-gallon buckets, can they get that water back out?
Yes.
Yes, they can. What if it goes to 3 gallons seeping in a minute?
Yes.
Can they do it? How about at 4?
Yes.
So how about if I go into 5 a minute? No. The tubular maximum is exactly like that. When you have too much sugar in your blood and it starts filtering through into your tubules, so it goes through the glomerulus and then the tubules, you have this rate at about 375 pieces is the way I like to think of it, per minute you can move. So if I have 200 pieces that are seeping in a minute, can I get them all back into my blood? If I have 375 transporters and 200 pieces fall in, can I get all of them back in? Yes. What if I hit 375? Can I get them all back in? Yes. What if I hit 376? What's going to happen? I start seeing urine in my glucose? Yeah, I say that once in a while too. So I start seeing glucose in the urine at that point. I've exceeded my tubular maximum. I've hit that point where I don't have any more transporters. You have to have a transporter for sugar. If you don't have enough transporters, you can't get all the sugar back in. Right? Threshold is the point where you start seeing that in your urine. So threshold is at the point where you've exceeded the number of transporters. You're pushing more sugar into your filtrate than you have transporters to bring it back in. So tubular maximum is the number of transports you have. That's the number you can transport. Renal threshold is just 1 point higher. So you just have to understand both concepts. To me, they sound exactly the same. It's just if you use them in a technical term and you're talking to a urologist, they have different meanings. Maximum is the maximum you can move at one time. Threshold is when you've exceeded the maximum. Right. So here's the little chart that your book uses. So if we look at that filtration rate, remember we talked about this before. Every day you pump out you filter about 92-liter bottles of soda a day, right? Do you urinate that many out? No. So you filter that much, but then you have to do what to bring it back into your blood? Reabsorb it. So if we look, every minute you're filtering about 125 milliliters of fluid. If I have 80 pieces of sugar in there, that means every minute I push out about 100 pieces of sugar. Can I catch all that sugar if I have 375 transporters? Yes. So how much do you see in the urine? 0. How about if I get up to this 200? So now I have my concentration is 200 parts sugar in my blood. Still the same GFR. This doesn't change at all, which means now I'm pushing out 250 pieces of sugar every minute. Can I catch it all with those 375 transporters? Yep. So I reabsorb 250, which means I push none out. But what if I go up to the 400? That means I'm pushing 500 pieces of sugar into my filtrate every minute. Can I catch all of it? Not possible. So I'm going to see about 125 milligrams per minute of sugar pushed out into my urine. When a doctor wants to know, are you filtering sugar properly, or are you filtering things properly, they can take these measurements. They may have you do a 24-hour urine catch where they give you that jug that you pee in all day, and you bring it in the next morning, and then they measure your concentrations. They measure the amount of fluid that you urinated out for the day, and then how much of that had sugar in it. And they can see, are you properly filtering? So if you really want to screw with them, you just eat a bag of jelly beans, right? Or you just drop a jelly bean in your urine and let it dissolve in there. And they go, ah! But that's what tubular maximum is. So tubular maximum, remember, is the maximum that you can reabsorb. And you have this magic number. What was the renal threshold? 1 above that. So as soon as you exceed it, so when you hit that 376, bink, it starts showing in your urine. That's the renal threshold. All right, next, phosphate. So phosphate's another interesting one. It's actively reabsorbed. Phosphate actually helps you maintain acid-base balance. So is it important? Yeah. Sugar is not regulated by the kidneys. You have those 375 sugar transporters, they're always on. Whether you have sugar in the filtrate or not, they're just spinning and spinning and spinning and spinning. You put 10 pieces in, they go zoom, and they pull them right back out. You put 375 in, zoom, pulls it right back out and puts it in the blood. You hit 376, they're constantly spinning, they can't spin any faster. You push out what? 1 piece. You bring 375 back into the blood and you push 1 piece into the urine. So you have to hit that point. It's not regulated at all. Phosphate is. If you bring in too much phosphate into your kidney and you need that phosphate back, your kidney will say, and it'll start actually actively transporting just the phosphate and start pulling it back in. Because it's important. If you bring in too much phosphate, then it screws up your acid-base balance. So it's just one of those exceptions where you have to watch phosphate. It's regulated by the kidney, so it helps you regulate acid and base. If you need more of it, you reabsorb more of it. If you don't want it, then you stop turning those transporters on. Right? And then the chemical, the hormone that controls it is called parathyroid. What's interesting, you'll see this later, parathyroid hormone controls two chemicals, phosphate and calcium. If you stick those two chemicals together, you know what you make in your body? Bone. So your body is going to help regulate your bone production or your bone breakdown by regulating this phosphate too. So it's acid base and also bone maintenance. And you don't have to remember that for this right now, but it's something you want to store in your mind because when we get to the endocrine system, this hormone is going to come back and phosphate's going to come back. Give me a little foreshadowing. All right, so we've talked about glomerular filtration, we've talked about tubular reabsorption, now we're going to talk about secretion. So tubular secretion. You're pulling things out of the blood and you're pushing them into the tubules. You're secreting them. Right? It's an active process. Is it important? Yes. If you're putting energy into it, it's important. Was glomerular filtration an active process? It was passive. You're just filtering the blood through the little spaghetti strainers. But now, if you didn't filter it properly, if you left things that are toxic or dangerous behind, now your body's going to go, holy crap, we don't want this in, and it's going to actively pull it out of the blood and push it into the kidney tubules. Right? So it looks like transepithelial transport, but backwards. It goes from the blood to the interstitial fluid, across the basolateral membrane, into the cytoplasm, and then out the tubular membrane. It's the same 5 steps, just reversed. So the key ones you want to pay attention to, acid, and what's this guy? K+. Potassium. We already talked about potassium a little bit. Potassium, when you flip on what kind of pump you move potassium? A sodium-potassium pump. Yep. Hydrogen, another key with hydrogen, it's not reabsorbed. So when you see this is secretion. You're always pulling it out of the blood and putting it in the tubule so you can push it out in the urine. What's that going to do to the pH of your urine? More acidic or more basic? More acidic, which means it's going to lower the pH. So hydrogen only gets secreted or filtered. It never gets reabsorbed. Right. Where it happens, the proximal tubule, the distal tubule, and the collecting duct. Did you catch where I told you glucose was reabsorbed? I give you an example with my sister's purse. Yep. So almost everything that gets reabsorbed except sodium gets reabsorbed primarily in the proximal tubule. What about amino acids? Where are you going to absorb those then? Also the proximal tubule. This one you have to watch. This is really important because at the proximal tubule you can push some out. So if your blood's too acidic, you'll start cranking the stuff out the proximal tubule. Then when you get to the distal tubule, your body looks and says, is this concentrated enough? Do we have too much acid? If not, we can push some more acid out. So 2 places that you secrete acid. Next to potassium, like I said, potassium can be actively reabsorbed in the proximal tubule before, but it can also be pushed out when you pull what ion back in? Sodium. So when we talked about the sodium-potassium pumps, we talked about in the distal and the collecting tubules. Remember, 8% of the sodium can be actively moved to the distal and collecting ducts. So when you're actively secreting potassium, it's back there at the distal collecting ducts by that sodium-potassium transporter. What did aldosterone move when we talked about it earlier? Sodium. It pulls sodium in. So I didn't tell you this part, but well, I did, but I didn't tell you the connection. If you're pulling sodium in, what are you getting rid of? Potassium. So you have to think of aldosterone moving potassium too. So if I release a lot of aldosterone, I start keeping lots and lots of sodium, but what am I losing a lot of? Potassium. So I need to up my banana energy. Right. And then organic things that are typically, if they could potentially be toxic, like penicillin. If you get high amounts of penicillin, your body just hates this stuff, so it's actively trying to get rid of it through your body. It filters it out, and when it doesn't filter out, it's going to actively pump through secretion. So penicillin is a good example. And then here's the example with potassium. So remember the sodium-potassium transporter. Where are these found? Proximal tubule or in the distal tubule? Sodium. Where can you adjust the sodium? Where can you voluntarily adjust sodium? Proximal or distal? Distal. The sodium's always the same at the proximal. You can adjust it at the distal. And it's because of these sodium-potassium transporters. So this is in the distal tubules. We talked about aldosterone already. So aldosterone, remember, is affecting sodium, but it's also affecting potassium. So if aldosterone is pulling sodium in, what's it doing to potassium? If it's pulling sodium into the blood, it's doing what to potassium compared to the blood? Pushing it out into the tubules. So which one is true about secretion? How about number 4? I'm just shooting from the hip on that one. But so is glucose secreted? Is glucose important for your body? Do you ever want to secrete it? No. It gets accidentally filtered, but then it gets what? Reabsorbed. So you know number 4 is wrong. How about hydrogen ions? Do they get secreted? Yes, but they never get reabsorbed. Yep. So number 3 is the correct one. How about number 2? Sodium is a substance that is secreted. Did I talk about sodium being secreted anywhere? For a reason, because sodium is not secreted. Sodium is reabsorbed in the proximal tubule. Sodium's not reabsorbed or secreted in what limb of the loop of Henle? The descending. And then what happens at the ascending limb of the loop of Henle? Sodium is reabsorbed again. What about in the distal tubule and collecting duct? Sodium is reabsorbed again. Sodium is only filtered or reabsorbed but never secreted. And then number 1, secretion is a process where substances go from the lumen to the capillary. If it's going into the blood, what do we call it? Reabsorption. So we know number 1, number 2, and number 4 are wrong. Number 3 is the right answer. Okay. This, when I was in grad school, the urology teacher that I had said that this is the toughest concept in medicine, and it's not that bad. But yeah, and we spent like a day and a half talking about this. But it's a simple rule, and this is what I figured out, is why it's so complicated is because we don't really know how to think about measuring something that's invisible. As a typical lay person, you don't really think about it. But this process is called clearance. It's talking about plasma clearance. You're not measuring your plasma directly. You're measuring what you pee out. You're measuring your urine. So we're trying to measure how much plasma goes through the kidney and gets actually cleared of substances as it's going through the kidney by measuring what you pee out. So it's like having a measuring tool for measuring something you can't actually touch. You have to indirectly measure it. So here's something you already learned. So 1 milliliter of urine per minute is excreted. That's about 1.5 liters a day is how much urine you put out. How much is filtered in a day? About 92-liter bottles. So that's 180 liters. That's how much you filter, but how much you excrete is 1.5. So that means the other 178.5, is that right? Get reabsorbed. They have to be pulled back into the blood, right? And this is where you want to underline or put a star by. It says plasma clearance refers to the volume of plasma that's cleared of a certain substance every minute. It's not the substance you're measuring. It's the amount of plasma it took to move through the kidney and get rid of that stuff. So when we start measuring things like that creatinine later, they measure plasma clearance based on creatinine. You're measuring how much creatinine is in your urine, but the problem is that it's not the creatinine you want to know. It's how much urine did you move through the kidney. That's why it gets tricky. That would be like me saying that, let's say I have a friend that's upstream in a river. And in this river, we don't know how much water is moving down the river. So what we do is we put 150 bobbers in per liter of water up here. And then as it goes downstream, I have a little net that just catches bobbers. So if I put 150 bobbers upstream, that meant there was 150 gallons of water, right? If I catch, 1 minute later, if I catch 25 bobbers, how much water moved through there? 25 gallons of water. Does that make sense? You're measuring the bobbers, but the bobber's not what we want to know. What did we really want to know? How much water was moving. So that's what you're doing with the kidney when you measure plasma clearance. You're measuring something, and we can actually put those bobber-like things in your body. We can put a chemical in your body that it's called inulin. It's an extract from an artichoke. Your body hates this stuff. So we can inject it into your blood, and then we can measure how much comes through in your urine and determine how efficiently your kidneys are working. We're not measuring it for the sake of saying, oh, look at this. We're putting this stuff in their blood, and look, we can count how many pieces. That's cool. We're measuring it to see how much how much plasma flows through your kidney to make the urine. So that's why they think it's so tough, is because you're measuring the invisible with something that is visible. It's a strange concept, right? But the key here is it's the plasma that you're clearing, not the number of the substance. So how they do it, and this is a little equation I'm not going to make you calculate, but to calculate plasma clearance, what they look at the urine concentration of the substance. So they make you pee in a cup or a jug. They measure your flow rate. So how much urine did you produce over this 24-hour period? How much of that product is in your urine? And then they divide it by the amount that was in your blood. So if we injected this inulin into your blood, we know that there are 150 pieces of inulin in your blood. 24 hours later, we're going to measure how much of that inulin actually got into your urine. So we measure how much urine you have and how much that concentration of urine is. It's the concept that you have to understand. It's the plasma that you're clearing is what you're trying to measure. Right? So here are the three big principles or rules you want to watch for. So if a substance is filtered but not reabsorbed or secreted, its plasma clearance equals GFR. What was GFR? Glomerular filtration rate. What was the number I told you needed to remember? It's 125. Yep, it's 125. So your GFR is 125. So I think I have a picture here. Yep. So if I push this substance into your body and it goes through and it gets filtered, if there are 125 pieces that got filtered, how much should show up in your urine? 125 pieces. It wasn't reabsorbed, no more is secreted, so what gets into the tubule stays in the tubule and gets excreted. So for a substance that just gets filtered, your clearance rate is going to be exactly the same as GFR. And that's kind of a measuring stick, that 125, and that's why I told you want to remember the 125. Okay. The next one, for a substance that's filtered and reabsorbed. So what's happening? If I filter it out, but now I'm reabsorbing it back, what's going to happen to that number that make it to my urine? Higher than 125 or lower than 125? It's lower. I'm putting 125 into the filtrate, but then I'm pulling some back, which means that less is going to go in. What's one substance that you're going to have filtered but 100% reabsorbed if you're a healthy person? Glucose. Glucose is the perfect example to help you remember that. What should your clearance rate of glucose be? 0. It should be 0. And this last one, for a substance that's filtered and secreted, so that means you filter it, you push stuff into the filtrate, and then when you secrete it, you add more to the filtrate. What's going to happen to the amount you put out in your urine? Is it going to be 125, less than 125, or more than 125? It's got to be more. It has to be more. If you're filtering it up here, and then you're also secreting it, oops, there we go. So if you're filtering it here, and then you're secreting more, it has to be higher. All right, so here are just the examples from your book. This is the one that's filtered but not reabsorbed and not secreted. What would the GFR and clearance be? Both would be 125. In this example, here's something you filter, but you 100% reabsorb it. What's your clearance going to be? 0. What was the example you want to remember? Glucose. Okay. Here's one that's interesting. So you filter it, you reabsorb about half of it. What would that be? Urea. So here's the next thing. What would the clearance be? About half of 125. What is that, 62.5? So about half of it. So if you're measuring how efficiently somebody pushes out urea, what should their urea rate be? About 62.5. What if it was only 30? What might be going on? What might you have to worry about them getting, actually? Gout. Yeah, you'd have to worry about gout. So it's telling you their kidneys aren't efficiently pushing out the urea. Okay. Substance that you filter and you actively secrete. No reabsorption, just filtering and secreting. So if I push out 125 pieces here and I add like 60 more pieces, what's going to happen here? It goes up, so it would be way higher. Good example of this, the plus sign kind of gives it away. Something that can be really dangerous to your body if you get too much of it. Acids, H+. So acid's a really good one to remember. What was the name of that drug that I told you your body would do this to? Penicillin, yeah. Back in the day, when they couldn't make enough penicillin to keep up with it, they would have people drink their own urine because that's good penicillin right there. So if you wanted to get better, you would drink your own urine. I kind of wonder, would I rather die? So exactly how sick will I get? Yeah. All right. So if substance X, whatever this thing is, has a plasma clearance of 200 milliliters per minute and the GFR is 150, what process is going on? Well, right away you know filtration had to be happening because filtration is the first thing that's going to put this stuff out in the filtrate. What's the second process that has to happen? Secretion. Yep. So you have to do tubular secretion and put it out. If you reabsorb, what would happen to this number? Would it be higher, lower, or less than 150? It would be less than. And excretion is not a process we talk about here. An exchange? What the heck? This is a chemical that you use kind of as a gold standard. So it's called PAH, or para-aminohippuric acid. But this is for measuring plasma flow. Your body hates this stuff with a passion. So should it be the same as filtration rate, lower than filtration rate, or higher than filtration rate? It should be higher. Your body hates it. What's it trying to do to it? Get rid of as much as it can. So it's going to filter what it can out, and then what's the other process you're going to use? Secretion. So what's the other medicine that I told you that was like? Penicillin. Yeah, your body hates this stuff. So with PAH, or para-aminohippuric acid, your body's trying to get rid of as much as you possibly can. It hates it so much that it's the best measurement for determining flow through the kidney. We can give you a big dose of this stuff, and your body goes black, and then starts pushing it out as fast as it possibly can. Okay. So what we can do, we can measure two things. The first one we can do is for filtration rate, GFR. We can measure something that's exclusively filtered but not reabsorbed and not secreted. A good example of that would be that chemical creatinine. Where does your body make creatinine at? Inside, I think I heard it, inside muscles. And like I said before, we can measure, bless you, we can measure how much creatinine your body is making every day based on your height, whether you're male or female, how active you are, etc. So the doctor will look at this and they'll go, okay, well this person's GFR should be at 125 because we measured the creatinine. Oh, look, it came out right. Next thing they do is they give you a big dose of PAH, and then they measure your urine production, and the PAH should be, I think it's 575 written down. Should just commit that to memory. I'm not a urologist. I would never ever be a tinkle doctor. Just for the record. Where did I put it? 625. I was off. So 625. So if you took 125 divided by 625, it comes out to 0.20. If you made that a percentage, what percentage is your filtration? 20%. So it's telling you of all the plasma that's flowing through your kidney, you're filtering 125 milliliters per minute. So the amount that you filter compared to what goes through is 20%. That means 80% of your blood goes through your kidney unfiltered. It moves right on through. So the percent of your plasma that's being filtered is 20% of your plasma. And that's filtration fraction. Oh boy, we're back to these. So this is a new section. We're going to talk about something called the countercurrent system. So the countercurrent system is there to help you concentrate your urine. When we talk about this, you have to remember these terms. What does isotonic mean? The same water concentration, right? Or solute concentration. Hypo means what happened to the solute. Solute went down. So what happens to the water? Water went up. How about hypertonic? What happened to the solute? It went up, so what happened to the water percentage? Went down. So hypertonic means it's really concentrated. Hypotonic means it's dilute. Isotonic means it's the same as the blood. Remember, the blood's your reference point for all these different things. So your blood's osmolarity, talking water solute concentration, is about 300 milliliters. Milliosmoles per liter. 300 is the magic number. So if it goes below 300, 300 I always think of as being the solute. So if the solute number drops below 300, what happened? Is it becoming more concentrated or more dilute? It's becoming very dilute. Yeah. If it went over 300, that means it's becoming really concentrated. So hypertonic. Right? And it's this countercurrent system that regulates this process using those three things. The renal medulla, where's that at? The outside part of the kidney or the center part of the kidney? It's the center. What do you call the outside edge? Cortex. Yep. So the cortex is isotonic to the blood. What's it telling you? What's the magic number for isotonic to the blood? It's 300. The cortex is 300, but as you go deeper into the medulla and you go deep, it becomes what? Hypo or hypertonic compared to the blood? Hypertonic. The number of solutes raises. So up here in the cortex, the blood comes moving in through the hillux, it comes out to the cortex, it goes filtered through the nephrons, and as it goes deeper down that descending limb, it goes deeper into the medulla. What's happening to the concentration down there? It's becoming really, really concentrated. So here's the same as the blood, and then you're pulling more and more water out of your urine, making it really thick as you go into the medulla. Right? So the medullary countercurrent system, what you want to remember are three parts of it. First, I would underline the long loops of Henle. So the long loops of Henle are the first part, and they establish this thing called the vertical osmotic gradient. They're the reason that you get this more and more concentrated. So as they're going down the descending loop, that long loop, it pulls out more and more water from the filtrate, and it makes it more and more thick. That's the first part. Second, the vasorecta. What was the vasorecta? Were they tubules or blood vessels? I think I just heard it. They're blood vessels. So the vasorecta, remember, was an extension of the peritubular capillaries. They're blood vessels. They're constantly flowing with blood. Anything that gets pulled out of the tubules is going straight into the blood and getting shuttled off really quick. So this vasorecta doesn't create that high concentration, it just maintains it. So anything you pull out of the tubules, you're going to put in the vasorecta and it takes it out of the kidney right away. It helps maintain that concentration. Right? And then the last one, the collecting tubules. The collecting tubules, they help modify the concentration gradient. And it's because of this hormone vasopressin, or what was the other hormone that we talked about? Not angiotensin, the one that works on the actual kidney. Aldosterone. Yep, aldosterone. So we're going to talk more about vasopressin, and vasopressin regulates the water. Aldosterone regulates the what? Yep, the sodium. Whoops, there we go. So the first part that I told you we were going to talk about, the loops of Henle. So the juxtamedullary nephrons are the ones that go where? The short ones or the long ones? They're the ones that go way deep into the medulla. Yep. So they're the juxtamedullary. They go way down deep into the medulla. Those are the ones that are going to do most of the concentrating of urine. In the process, he uses something called countercurrent multiplication. It's kind of interesting how this works. It's kind of like, to me, when I look at this, it's like the chicken before the egg. So what you need to remember is that 65% and 35%, when we talked about the proximal tubule, most of the sodium and most of the water is going to be reabsorbed. If I reabsorb about 65% of the sodium, how much water am I going to reabsorb? About 65%. Where you take the sodium, you take the water too. So that remaining 35% of the water that's in the urine has to be modified. Right now, it's the same osmolarity as the blood. What do you call that? Isotonic. So in the proximal tubule, that's in the cortex. It's still isotonic, but now it's going to start descending. It's going to start going down deep into the medulla. So what do you think is going to happen to the water? Is it going to move into the tubule or out of the tubule? Out. It's going back into the blood. What's it going to do to the urine now? Makes it more and more concentrated. So you're going to start pulling more water out. So the descending limb is permeable to water, but not to salt. Did you know that? The descending limb is not permeable to sodium. Yes, you did. When we talked about the places you reabsorb sodium, what was the one place you can't reabsorb sodium? The descending limb. Yep, 0% was reabsorbed in the descending limb. Right, so the water moves out by osmosis, and since the water is moving out, what's happening to the urine? It's getting more thick and concentrated. So is it becoming hyper or hypotonic? It's becoming hypertonic because it has more solute and less water. It's becoming thicker. Right? So it decreases the volume of water, increases the concentration of salt. And then when you start going up the other side, the ascending limb coming back up, can salt move? Yep. So salt's going to start moving when you're coming up, but water can't. So they reverse their rules. Water can move going down the descending loop, but it can't move going the ascending. What can't move in the descending limb? Salt, sodium. And sodium starts moving when you go up the ascending limb. So they reverse their rules. So this is how it goes in your book, step-by-step process. And like I said, this is like a chicken before the egg. So at some point before you're born, what will happen is you start pulling some of the water out on this side. This is the what limb? Ascending or descending? Descending. It's going down. You start pulling water out. And you're going to pull the water out and put it into the vasorecta. Right? Up on this side, what are you going to start moving? Sodium. So let's say I turn a sodium. How do you move sodium? Actively or passively? Actively. So what am I turning on? I almost gave it away. A sodium pump. Yep. So you're going to turn on a sodium pump. You're going to push the salt out here. This is kind of cool. Water moves passively. So the water from here is going to start doing what? Try to come out here to meet the salt. If I push the salt out from this side, the water chases the salt from that side. Can the water move over here? Nope. The water starts detecting the salt over here and starts moving out. So as I start shifting this over, it looks like this. When they put the little circle in the picture, it means it's a pump. So you start pumping the sodium chloride out here, and it's going to start pulling the water. Right? And then I just keep doing that. I keep cranking the pump up. Bink. So I turn the pump a little higher, pull more water out. Turn the pump a little higher, pull more water out. And I just keep doing that until I eventually get where it's about 1,200 down here at the tip, but 300 up here at the cortex. So as that pump keeps pulling and pulling and pulling, it's pulling more water from this side. And I said, which one starts? Hard to know. Just the sodium's going to have to work and the water's going to have to chase after it, so they just kind of mutually start meeting. Where that stuff goes is into the vasorecta. What was the vasorecta? Blood vessels. Yep. So the vasorecta goes through a process called countercurrent exchange. And what it's doing is anything you pull out into the tissues, instead of creating edema in the tissues, the blood's going to catch this stuff and shuttle it out of the kidney really quick. So they start putting the water into the vasorecta. It shuttles it back up, pumps it out into the venules and into the veins and out into the regular circulation. Right? And I highlighted this before. I told you before when we talked about the 3 steps, number 2 step was the vasorecta prevents the breakdown of the concentration gradient. It doesn't make the concentration gradient, it's there just to maintain it. It just takes anything that the kidney wants to get back into the blood, it takes it, pushes it back into the circulation. It's not a big deal. It's not going to do any pumping, it's not going to do any special moving, it doesn't create the gradient, it just maintains it. And then everywhere you follow it along, so I think I have a picture here, as the blood vessels go down next to the tubule, it just passively moves things back and forth. So if I start adding salt to the tissue will push it, the medulla tissue, will push it into the blood, and the blood just carries it right along. If I add water, it pulls it right along. It's going to constantly be moving things back and forth the whole way. The blood always stays isotonic to wherever it's at. So when you measure the blood's tonicity down here deep into the medulla, the tonicity is going to be the same as the medulla. As it starts going up, it's going to stay the same. It always stays consistent with the medulla. Right. So you can see it just moves right along. When it comes into the medulla, it stays at 300. When it leaves the medulla, it stays at 300. It's just there to catch any extra stuff that your kidneys start pulling back to the blood. Right. So if you were asked a question like this, which is a true statement about the osmotic gradient? And this is kind of like that one block. How about number 1? The loop of Henle is permeable to water on the descending limb. Damn again.
Yes.
The one time I don't shoot for number 4, look what happens. So water's permeable on the descending limb. It's not permeable on the ascending. What's not permeable on the descending limb? Salt. Cubs win the pennant! The Cubs win the pennant! Right, like that's ever going to happen. Right, number 2. Cortex has an osmotic gradient that goes from 300 to 1200. What do you know about the cortex? It's always consistent with the blood. It's isotonic at 300. What actually changes for 300 to 1200? The medulla. Yep, so you can cross that one out. How about number 3? The vasorecta created the osmotic gradient. Did I beat that one to death or what? So definitely not. It maintains it. It doesn't create it. Number 4, the name associated with the vasorecta is the countercurrent multiplication system.
What?
I think we learned that in kindergarten, didn't we? But no. It's countercurrent system, but not the countercurrent multiplication. The multiplication system is actually increasing, and that would be because of the descending limbs. So 2 through 4 are incorrecto. All right, back to aldosterone. So aldosterone, again, remember where it works? This is like, I think, the 3rd time today we've talked about aldosterone. It works at the distal tubule. Where does it come from? Adrenal gland. What turns it on or makes it release from the adrenal gland? Angiotensin-2, the sequel. Right? And then it stimulates the reabsorption of sodium. So it's pulling the sodium back in, and what's it do to potassium? Pushes the potassium out, right? And then you already know this. The water loves the sodium, so if you turn on the aldosterone, you're going to start pulling in salt, you start pulling in water, and you start pushing out potassium. Right. So remember your different structures again. Here you have Bowman's capsule. Is there any reabsorption at Bowman's capsule? Have we talked about that? None. Nope. You have filtration at Bowman's capsule. It comes from the glomerulus and gets filtered into Bowman's capsule. Proximal tubule, do you get any reabsorption there? So here I dumped everything out, and then what do? I start pulling it right back in as fast as I possibly can. Most of the reabsorption is happening at the proximal tubule. Glucose, amino acids. We talked about sodium being reabsorbed here. If you need to reabsorb potassium, you reabsorb it here. Do you reabsorb acid? No. What gets reabsorbed on the descending limb? Water. What gets reabsorbed on the ascending limb? Salt. What gets reabsorbed at the distal tubule? Salt and water. Yep. And then what do you excrete here? We talked about 2 things you excrete at the distal tubule. Acid and, what's the other plus? So 1 letter. H plus, and the other one's 1 letter. K plus. All right, next hormone, vasopressin. Vasopressin is also known as ADH, and you have to commit those 2 names. It means antidiuretic hormone. And I'll give you an actually moment. So the next time you're out, like on Friday night, and you're doing a little bit of drinking, vasopressin is released from your hypothalamus. Where's that at? In the brain. If your brain has a little too much alcohol, what's it start doing? Slowing down, right? So things don't work so well anymore. You start slowing your control of balance. You start slowing your speech. You start slowing your personality. You start slowing the release of ADH. ADH is an antidiuretic. What's it telling you it's doing? Pushing out water into the kidney or keeping it back in? It's keeping it. So if you don't have an antidiuretic, what happens to the water? You start doozing it, right? So when alcohol affects your brain, it's not, you don't start urinating more frequently because you drank, a certain amount of water. It's because you turn off this ADH. Now you don't have the chemical to reabsorb water anymore. So what happens to your urine? You start making lots of it, and lots of it, and lots of it. I'm just thinking the last time I drank, I don't think I made that lots. Maybe lots, not lots and lots and lots. And then what's going to happen to the color of your urine? Very clear, because you're cranking out lots of water. If you actually measured how much alcohol you took in compared to the amount of water you urinated out, you'd be urinating lots of water out. It's not because, oh man, I've drank so many fluids, now I have to tinkle. It's because you drank a lot of alcohol. Right? So alcohol turns this off. Where it works, same place as aldosterone. So it works at the distal tubule and the collecting ducts. It does not work on sodium. It doesn't work on sodium. It works on what? Water. Yep. So vasopressin in the form vasopressin, it causes your blood vessels to start contracting. When cardiologists were studying this chemical, this hormone, they look, if we put vasopressin on a blood vessel, it makes it contract. What's it going to do to your blood pressure? Increase it. Same time, urologists were studying it, and they said, hey, look at this chemical that when we expose it to the distal tubule of the kidney, it makes you push more water out. So it makes you, well, prevent reuptake. So you start losing more water. So we'll call it an antidiuretic hormone. When they published the research at the same time, the cardiologists called it vasopressin, the urologist called it antidiuretic. It's the same stinking chemical. It just has two effects. And that's why you have to know both names. So vasopressin causes vessel constriction. The ADH, which is the same thing, causes water retention. So if you drink too much alcohol, you turn off that, and you no longer retain the water. What's it make you feel like the next day? Dehydrated, yeah. What do we call that when your brain feels dehydrated? Hangover. Okay, so causes reabsorption of water, remember, it doesn't have an effect on sodium. That's something that usually gets people. Aldosterone affects the sodium, ADH affects water. And what it does, I remember ADH affects water, it's always digging holes. It puts these holes in the distal tubule to let water come back in. Because water wants to chase the sodium, right? But if you have no water holes, can it get through? Nope, can't get through. You have to put holes in there for the water to come through. So this ADH is always digging holes that allow water to seep back into the blood and chase sodium. Where it's made, you have to know, hypothalamus. And we'll talk about this again in the endocrine system. It's one of those hormones you have to know. So it's made in the hypothalamus, but what's interesting is that the hypothalamus doesn't release it. The hypothalamus stores it in the pituitary gland, and it's dumped out from there. And then what causes it to be released? Hypertonicity. So what's happening to your blood if it's hypertonic? Too little or too much solute? Too much solute. Your body has too much salt in it, is the way you want to think. If your mouth has too much salt in it, what do you want to do? You want to pull the water in, right? So you put water in your mouth. If your blood has too much salt, your brain says, whoa, way too much salt, what are we going to try and do to it? Dilute it. So what's it going to do? Yep, it's actually going to make you want to drink water, and it's also going to do what to the kidney? Pull the water back in from the kidney to dilute that salt. So that's one thing, hypertonicity. The other thing is hypotension. What's happening to your blood pressure? A drop. Why is it pulling water in then? To increase your volume, which increases your blood pressure. Right? So the hypothalamus detects these things. So for the tonicity, it's osmoreceptors. For the tension, it's the baroreceptors. So you have these little receptors. Where are those baroreceptors at? Yep, aortic arch or carotid sinus. And we studied those all back in cardiovascular. So when I look at this is the distal tubule. 5 minutes left. I don't know why I look up there. I know the clock's not there. Right. So the distal tubule, when you're looking at this, you have to pop holes in here. It's a passive process. Vasopressin is a hormone that travels through your blood over here. It seeps through and it binds to a receptor. It's a hormone. It's like a key. What's it looking for? Perfect lock. It slides into the lock, and this lock turns on a mechanism that pops holes over here by the filtrate. So now the water can start seeping in. What's the water chasing when it seeps in? Sodium. Yeah, if you just pop the holes in there but didn't retain any sodium, you're not going to retain the water. So they work together that way. So aldosterone and vasopressin work hand in hand. Aldosterone pulls the salt in, vasopressin allows the water to come in. And then the last slides we're going to talk about here. So here's how it works. If I push the urine in, or the filtrate into the tubule, here we have the descending loop. What am I pulling back in? Pulling back in water. Over here, you have these pumps, the sodium-potassium pumps, or sodium chloride pumps. You're moving salt, right? So you're constantly making this a little more dilute. God. We should just call it. When I start thinking about time, I start freaking out. Like, oh my God, 5 minutes. Oh my God, 5 minutes. Right? So now you're making this more concentrated. If I want to dilute it or concentrate or affect it, the last chemical is going to work right here on this limb. This part is going to be affected by vasopressin. If my urine is extremely dilute, it's very, very watery, what do you think I'm going to do to these water holes? Am I going to open more of them up and make it more dilute, or am I going to close them off? Close them off. If my urine is extremely concentrated and my blood pressure is high, what am I going to do to these holes? I'm going to open them up. So if I need to retain water, I release vasopressin and it opens these holes. If my blood pressure is too high and I stop retaining water, what am I going to do to the holes? Cover them up. I'm going to block them. If I block them, then I start pushing out this urine without being modified. And it's going to help me maintain everything. So, oops, sorry, forgot there's one more question. So which is true about vasopressin? Where's it made? Hypothalamus. So is number 1 right or wrong? Wrong. How about vasopressin stimulates reabsorption of sodium? What's it cause reabsorption of? Water. How about number 3? Vasopressin has another name, which is aldosterone. What's it called? ADH, antidiuretic. So we know number 3 is wrong. Vasopressin binds the receptors in the distal and collecting tubule? Absolutely. Allowing you to retain water. That's it. Next week, I'm just going to stop.